I would like to start our question and answer session and wonder whether you have questions which you want to ask here or in the chat.
I think it would be best, Krista, if they ask the question directly. You know, in terms of time management, it works better that way.
Yeah, so please, the floor is yours. Come up with questions to our 5 presenters.
Krista, I have some points to make to the presenters. I put it in the chat box, please.
Please do that. Yeah.
Yeah. Okay. Thank you very much, Sangmitra. She asks, what are the changes which the second step migrant nurses from the Gulf countries to the US and UK bring to their lives and to the lives of their kinship? This is addressed to Dr. Pakasama.
Yes, I'm sorry for misspelling the name. Sorry.
Yes.
Hello.
This is a question for Dr. Pakasama. Have you got it?
Yes, I got the question. And yes, I have interviewed nurses who have gone from the Gulf to the US. And this has happened mostly between 2002 to 2006, at least among all the ones that I questioned. And of course, I'll be getting more data. What I found is, what are the reasons for shifting from the Gulf countries to the US? One of the reasons was the Gulf was never permanent. That was the first reason. It was never a permanent residency. It was only for earning an income for a short time. Moving to the US would give them a better opportunity at permanent residency and citizenship. Part of their financial goal was fulfilled by savings from the Gulf. They have met their financial obligations for the families, and now they would like to do something better for themselves and their children. Most of these were young professionals who had done well, who had studied a little higher education and were looking for a better opportunity. And the change they found was, though all the technology and equipment and facilities were available in the Gulf, there was more independence and autonomy in the US and more dignity of work in the US. So I hope I've answered at least part. Yeah. There's a lot more complexity within this, not just as simple, but that would come later.
Yeah. Thank you very much for answering this question. Professor Sangmitra has written down more questions, but I have seen that Swati Rane raised her hand, and perhaps in between, Swati, you can ask your question. Welcome, Swati.
Thank you. Thank you, Krista. Good evening to all the speakers and the audience. It was a very insightful presentation, and thank you each one of you all for working for nurses. My question is to all the presenters, is that all the work what you all are doing is amazing. How do you think it is going to help the nurses? And what is your approach going to bring it at the policy level to bring this change? Because I know it is a tough question, but what do you think as experts? Because I am a nursing advocate working with the ground level nurses, and I see a lot of gap between the experts like you and the nurse at the bedside. And the nurse at the bedside doesn't know what great things you all are doing for them. So how are you planning to fill this gap? That is my question. Thank you so much.
I think that is a question to all the speakers.
Thank you. There is a question by Professor Sangamitra. I also wanted to add that, this why people are moving girls to these other countries. I think what was told by Professor, Prakasamma was saying that it is not a PR. They don't get PR in the Gulf countries, which is partly true. But our research clearly indicates they are going to Gulf to make money to move to those countries. They are earning money to move to those UK, US, Canada. I think this is something what I call them via Gulf. When I meet a lot of nurses from the Gulf, they say, we are here only for short term, we are making money so that we can go to Ireland, we can go to Canada, we can go to Australia. I think this is something we should look at it very carefully, because they are not using Gulf but they are using Gulf to make money to migrate to the better countries where PR is available, where they can move with their families, some more facilities and things like that. Now the question about this question which was asked, this why, how to reduce barriers, because I am more on barriers, because I see every day there are barriers to women migration, there are barriers by age, barriers by recruitment, barriers in the name of high money investment. And now I was told by one of the presenters that if they go to UK to do something, they have to pay more. Now this paying, I think this is something which I am very unhappy with that, because why should the Indian nurses are wanted in UK? Why the Indian nurses, their parents, and we should invest on them? If they are very keen, UK wanted to recruit. So UK should come and invest in medical colleges like Sasi is here, Manwar. They can set up. We have different seats for them, special training for them. This is special recruitment training. They should invest on them. Now they are exploiting the poor countries. Very unfortunate. They're exploiting poor country resources, poor countries' best mind, and then everything they do, then they want to recruit them. I think this is a very, very, very sad situation. I think this should be put to the countries like the big countries. They call big countries, but it's basically just getting the people to work for them. Everything done here. We put our money, we put our best children, then they recruit them. I think this is something we should talk about. The North-South collaboration of investing by those countries who want nurses from India. It includes Australia, Canada, UK, and the English-speaking countries. They should invest money, and so that they don't need to pay. Okay, there's a canon. If you study this course, we are sponsoring you. After that, you study 3 years. When you get the course cleared, you can work for 4 years. Those type of arrangements should come. But they are looking at after nursing. It's something very important, because what they are creating indirectly, there is a high inequalities being created. Only some people can go. So there is a barrier. Suppose a poor person who cannot get loan, who cannot have money to invest for their daughter's education, you are denying them to become nurses. I think then it's becoming a money. I invested money, I want to get money. So I want to go to America. So it's like a pure money is coming in, and the real service, what we are talking in the olden days on nurses, is coming down. I think it creates a higher inequality in the countries of origin. This is what I want to do. So I think for us, we have to think how to reduce the barrier, how those big countries can invest on our people's education, especially the nurse education, and then help them out. I will stop here. I have another question. I'll see if I can take it up later. Thank you.
Yes. Are there answers to Swati Rani's question?
I want to add something.
Yeah.
Yeah, to Swati Rana's question that how can we reduce or how can we bring about a change? Like I agree with Mr. Rajan, Dr. Rajan, who had just said that they should be investing money on the nurses' education in India, and then they can be taken abroad. That is one aspect, but we will not be able to identify that to whom to invest the money. But there can be some government policies where we can have some restrictions on what are the conditions under which these nurses, they will be moving abroad. So some boundary policies or some kind of migration policies from labor law in India that can be incorporated so that the nurses from India or from the developing countries, they are not exploited. It is not only that they have to pay money to get recruitment there. Many a times they will be hired on lesser salaries for maybe 2 years or 3 years, and later on they might be getting a sufficient amount of money. So by that time they are usually emotionally as well as physically drained also. So that needs to be avoided by having some regulations and some acts by the Indian government.
But
Yes.
maybe I'll answer Swati Rana's
Yes.
question. In the Canadian context, the research that I've done and that members of my team have done have been connected quite closely to, for example, the colleges where the Indian trained nurses are studying. So we meet with the nurses and we talk about the research, and in the act of talking about the research, of course, we get informed about their experiences, but they also get informed more about the processes they need to engage in. Also, we have engaged with regulators. Regulators tend to be a little bit kind of closed off, but they do get to hear about the research at meetings and presentations. And I have recently been working with the National Nursing Assessment Service, which is a Canada-wide assessment service that reviews the documents. And they have asked us to compile reports on nurse training in source countries. And so we have written one on India. And that allows them to have a baseline to work from, which then cuts down on the duplication in the documents that they request. So I would like to think that we're helping kind of streamline in the bureaucratic administration that happens in Canada in terms of that kind of assessment. And I do think that the regulators listen, and particularly during COVID-19, there was a lot of political pressure for them to streamline processes. So in terms of how are we actually helping out nurses on the front line, I'd like to think that we're helping to get the regulators to streamline unnecessary bureaucratic barriers, because as Professor Rajan said, you know, there are enormous barriers and we have to sort of think about how we can streamline those.
Yes.
Krista, I have a comment on the last responses. First one to Professor Rajan. Yes, there is a group who's in the Gulf mainly to make money to go to the US, but there is another group which doesn't have aspiration to go to the US, but to earn enough to have a better life. These are the two groups that I noticed. And the younger group is the one who goes for a few years to make money to go to the US. This plus the second comment I want to make, it's about the bilateral agreements, which I've come across recently. I'm not sure I have the full data on this, but Japan and India, I heard there's an agreement for training a few hundred nurses and giving a job placement for 3 years. This I heard from someone in Japan, from the ministry, health ministry there, but I do not have full information on this. And I'll be happy if you can provide that. Thirdly, Swati, my objective, which I mentioned at the beginning, was to go to the bedside nurses, the practicing nurses, and get their voices out. That's the purpose of these narratives, so that they are visible and their voices are heard. Hope I said something useful to answer the questions.
Yes. Ramila raised her hand.
You know, I'm really not an expert in this field, but from whatever we've been studying through this project, what we realized was that there are these whole lot of frameworks exist, international frameworks, codes, these bilateral arrangements are there. But if you review them carefully, how much teeth they have really, which is of benefit to us, is a question. Secondly, even through the bilateral arrangements, even if they invest in education in nurses for nurses here in India, majority of our nursing institutions are in the private sector. So, you know, that's also an issue for us. So if the investments, if they come into the private sector, then finally the private sector will charge their fees. So, you know, I think regulation is very difficult for almost all fields here. The regulatory, lapses are very large. International codes, international frameworks have to be reviewed really thoroughly to see how good they are, how much they can benefit. And third is the spread of our own nursing education. So even if we have investments coming into India to train nurses, I mean, we have to work this whole thing out. It's not so straightforward. Yeah.
Yes. Rajan has his hand up. Rajan,
Krista, there are some questions in the chat also, so maybe you should look at that. One was from Sanghamitra for Margaret, and then there, Helen Schwenken, she has a set of questions for Rajan. Yeah? So please,
Okay. Then let's first turn to Sanghamitra's third question, addressed to Margaret. Those nurses who register for PG nursing programs in Canada and then work, are they considered to be better than the INNs?
Thank you so much for this question. It's difficult to determine who determines who is better. I mean, I think what happens is if people find work, their experiences in the workplace can be very complex, but there is a sense that doing the further education prior to integration into practice, into the labor market, can be beneficial to address some of the issues Ramala suggested in terms of those soft skills. So there is 2 years of training that involves a lot of clinical updating, and that time training is considered part of their safe practice window. So that also benefits them when it comes to having their credentials assessed. There's a lot of understanding of the Canadian healthcare workplace, which is important, for when they eventually arrive at work and get onboarded. So my observation is that there can be benefits from being, having had those 2 years of training, and our experience working with our college partner is that many of those nurses who do graduate from the program do come out as registered nurses, and they do find work that is very, which is rewarding in terms of actually being a registered nurse, and they move all over Canada as well. They don't just stay in Ontario. So it's a difficult one to answer because I don't know who's making that determination, but I think based on the experiences of being in a good program of study, there are a lot of benefits that at the end of the day do help the nurse in integrating more fully and more effectively into the labor market as a registered nurse. Thank you.
Yes, Rajan, let's take Sanghamitra's, let's take Helen's question to you, and then you can answer and add something more. So her question is, Rajan, you mentioned that nurses now also fall under the immigration clearance regime. Could you please elaborate on that? First, policies behind it, and second, how does it work, and what are the effects?
Yeah, I think I will pick it up. I think this is something we recently wrote an article in Economic and Political Weekly on this, but definitely we will. We just published maybe not even few weeks back, probably. I think before that, I also wanted to, little bit to pick up on what Ramila said, because when you say that we are, the private institution will make, different fee structure. We are allowing the private institution to run hospitals now in this country now. There are big hospitals are run by private, basically by NRIs. A lot of hospitals are coming in Kerala, which I see NRI funding is coming in. And we also allow the education institutions. There are universities now, private universities coming, they are charging different fees, but even for BA economics, which is 5 times, 10 times higher than other universities. So I think they will come. I think if you like it or not, but then here we are talking about filling up the demand for that particular thing. If suppose Flame University training somebody on some subject, we are not worried. But here, these countries, they are telling we want nurses, and we want, they also give specifications. We want this type of nurses, this type of things. When they want it, and why should we train nurses for UK? Why should I train as put our taxpayers' money and our money to train my daughter to go and work in UK? Why should I train her? Why should I train her? I think this is some type of a big question I want to ask. Because why should I train her? To work there. I can train her to work in my country. She can work in my village. She can work in my hospital. There are patients. We have shortage of nurses. But still I allow them, let them go. No issues. They can go. They can make money, extra money. But then why should they invest money to study and then the benefits all goes to those countries. I think we have to critically question that, because that's what I'm talking about. Like still what's happening today, when there was a war zone happening, we met some people, nurses, they said, we paid 4 lakhs. We can't come now. Maybe if bomb is coming, because I have to get the money back. I already paid 4 lakhs. I paid the agent 3 lakhs. So I have spent 7 lakhs to work and earn the money. Now you are telling me there's a war, I will come and pick you up, but then who will pay me my money? I think this is something a very, very serious thing, especially the countries which has money. It's not a poor country. If somebody in Nigeria wanted some nurses from India, I don't mind. But the big rich country, they talk so much about equality, sustainability, all those things. They have to put some money, which I'm very serious about that, because they should put some money on that. Now that the question on this, the Kerala, not Kerala, the POE system. What happened during some time back? There was some issue with the nurses. The government of India has put them with what is called the ECR passport. They said if you want to leave the country, you have to go through only few agencies where you can be recruited. Now it has a massive attack on the women's mobility. You are treating them like like an unskilled worker. It is like they are treated like a domestic servants or domestic workers. It's very, very unfortunate. And who is fighting for them? And nobody was talking about them. We were talking about them. We told the Kerala government was talking to the Indian government, and they said there are problems. But now what made for these people, nurses who want to move, they are paying now more money to go through some agency. They are paying to go on some visa. In fact, some people went on a domestic worker visa and then go there and then work as nurses. See, you are creating a huge network of undocumented migrants in the name of policy regimes. I think this has to be relooked at it. I think we are talking every day in and out, but it takes some time. But I think we have to put up a joint interest on that, because at the end of the day, if you're a nurse, if I am allowed to go, why should my sister who has studied nursing not allowed to go? I think we are talking about equality. We are talking about So I would like that barriers for women mobility, not just nurse workers. Women mobility at every point of time, starting from pre-departure, destination countries, and then return migration, rehabilitation, everything. How many policies you have for women return migrants? Do you have any special program for them? They are a different group of people. So I think we should work more seriously on this, just not nurse migration, but on the general women's migration. I think we need to do a lot of work. I think we need to do a lot of homework. I always feel we have to do homework. I think India has to do homework and other countries should do homework. Start you need some people and we give you. So it's like, no, I think we have to think the long-term sustainability of this. I'll stop here.
Yes, thank you very much, Rajan. I would like to take in now the question by Maike Jäger, who is actually the person in charge for the programs I mentioned earlier at the German embassy. And she has asked, how do the speakers look on the uneven distribution of nurses in India, and that so many states do not match the WHO requirements on the patient-nurse relation? What should be done that inland migration get also a push? How can salaries and working conditions faster improved? Visibility was mentioned. So I'm afraid that Michael left just now, but still, I think we should take up this question. Who would like to answer this question?
I think, Krista, I would like to make an effort.
Yes,
because my organization Answers is committed to this, and we work with every state to advocate for nurse-patient ratios. And we have done situational studies and shown to the state governments and to the national government how dismal the situation is in India, while we have a very different ratio, not only north-south, but private to government hospitals, government hospital at different levels. And these are issues which we can make a stronger voice at the state level through the state professional associations and the national association, plus with policy briefs given repeatedly As an advocacy organization, we find that advocacy and policy intervention has to be a continuous process, and it is a process with very little gain or profit or satisfaction, but it has to be continuous. And we do it every day, almost every day, especially for the uneven distribution across the states and within the sectors, private and government sectors, and at different levels in the government, tertiary hospital to district hospital. And within that, also between different departments. These are the different problems we have, and we need to work with that. And any international intervention will be welcomed. We have not had much success with WHO intervention or any other UN agency intervention. Not even with professional association, large organizations like ICM and ICN, but perhaps with some writing visibility, some change will come. Thank you.
Thank you very much, Dr. Prakasama. Somebody else wants to answer this question? Otherwise, I raised my hand and would like to ask a question. Looking at this German recruitment program called Triple Win program and others, what we heard here today, I wonder whether we are moving toward a new international division of skill training in the global south and skill utilizing in the global north, facilitated by market agencies and market mechanisms. I think this is a crucial question: who bears the cost of skill training? And we had different hints at the fees and the debt involved in this. And yes, is this a tendency which would make for really a new inequality in the global market? Raveen.
Yes, no, I just want to add what you said. You know, on this, there has been a very long history of discussions and debates and so on, broadly under the rubric of what is known as brain drain, right? And, you know, these debates started in 1950s, focusing on particular segments, etc. So I think there are large number of issues there which are still very, very pertinent, and it would be very useful, although we have more or less run out of time, if some of the experts in this area also, while answering you, that debate. Yeah, the debate regarding brain drain and, you know, what it means in terms of implications for global north, global south, and so on and so forth, right? Some of the issues were already flagged by Professor Rajan, but I think these are indeed very, very substantive questions. And also, I mean, I think a deeper kind of understanding of the situation in destination areas, not simply looking at some economic gain, some economic benefits, some of those things could also become more substantive kind of issues in the conversation. I hope I have made myself clear, Krista.
Thank you very much, Raveen. I would like, we have 3 more questions, one by Arunima Ayar in the chat. Question to all experts. I wanted to know if you have encountered situations of recruitment and migration of male nurses. If so, could you please elaborate on their barriers and if migration provides a better opportunity? Who could answer this question?
I'm happy to talk about male nurses just quickly. The research I've done in Canada with those who had taken the sort of 2-step student pathway found a disproportionate representation of male nurses. It was an opportunity that was sought out by male nurses. And the literature more broadly about men in nursing indicates that they tend to benefit from being in a heavily feminized profession. Male nurses tend to have more full-time employment. They tend to rapidly move through the profession. They gain benefits from being a male in a feminized profession, in part due to how the assumptions about their responsibilities are somewhat different. One might assume a female nurse needs to perform in a certain way and express her empathy and emotion in a certain way, and those expectations are not necessarily applied to male nurses, so they're given more room to be a little bit more distant from the patients, a little bit more kind of superior and managerial, if you want. So there's a lot of literature out there on how men benefit from being in nursing, but research I have done has indicated the overrepresentation of males in the migration pathways because it's an opportunity, and I think they recognize that and embrace that opportunity and really work for it. So certainly that's clear. And there was a question, Krista, to the question about the issue of training. I do think that's a really important one. I think others probably have some interesting observations to make on it. One of the things that I would say is that training is the responsibility of all countries, including India. If India wants to control the out-migration of nurses, then they should pay nurses better. They should improve the status of the profession. They should engage in structural transformations in training. For example, I know there's talk about engaging in, for example, nurse practitioner training. That's significant, requires a structural overhaul of how India views nurses and nursing, and that hasn't necessarily been seriously engaged with. And then for receiving countries, we can see, I mean, I think the work on that Ramila showed on the UK, they don't have enough nurses. Well, they have to ask the question, why do we not have enough domestically trained nurses? It's because the profession is not attractive enough, it's not paid enough. The UK government even makes an exception for nurses, so migrant nurses can get a skilled visa when the income they earn is not enough to meet the standard requirements that the UK government has for what determines whether an occupation can apply for skilled visas. So countries everywhere have to do more to invest in the health and care professions, to improve the status of working, and that includes paying for training. That would be my response to one response to your comment, Krista.
Thank you very much, Margaret. Azra, did you have a question?
Yeah, Professor, I have a question, but I think Dr. Sashi has left, one who wants to be answered in these questions. So thank you so much for insightful presentations. My question is that for the India, so Dr. Sashi has said the government put a lot of effort to improve the condition for workforce in the public sectors, and the nurses are migrating within the state east to south. So within the state, how do you see the future outlook for nursing within the state? Or what step can be taken to make sure everyone has to quality healthcare? Yeah. Does anybody wants to answer me?
If Professor Rajan is still there, then maybe he can sort of, since he has worked on these issues within the country and outside, maybe he can engage with this.
No,
otherwise, maybe Ramila.
I didn't get that question correctly. If you can repeat the question, then maybe I can.
Please, Azra.
Yeah.
Repeat it.
Actually, my question was that Dr. Sashi said the government has put a lot of effort to improve the public sector to provide the government to better condition for workforce. And nowadays, nurses are migrated within the state east to South India. So my question is that how do you see that the future outlook for nursing within the state, and what step can be taken to make sure everyone has to quality healthcare within the states, and how they could be overcome that shortage?
It
Maybe
comes a
Margaret
little bit to the same question like Maike, the question Maike asked. Rajan, do you want to?
Related to Michael.
No, I thought Margaret can answer this much better, probably. Margaret?
Krista, could I answer her question? Because I have worked in this area. My PhD was on nursing, work environment and issues.
Swati, of course, please.
Yeah, thank you. Asra, the problem of India is we are not having shortage of nurses because we have a lot of colleges for nurses, but the quality of the education is very poor. So the nurse who comes out, you cannot guarantee, even if she is registered nurse, she is having a quality education. Okay. And now the thing is, in South, traditionally, the nurses have been getting good education in nursing, and that is the reason many of the South Indian nurses are going abroad. So there is a lot of vacancy, but that you will see only in Kerala. But if you see in Bangalore, there are small boxes like, nursing colleges which are just issuing certificates. They hardly give any good trainings. So that is the reality of South, and that is the reason there are more hospitals, private hospitals, corporate chain hospitals in South, and there is a lot of good quality nurses in South. So most of the Northeast or North India nurses, to get good experience in good hospitals, they are moving to South. So that is one reason I find. Second reason is that, again, Northeast, as Shashi ma'am said, the political situation is very bad. So nobody wants to risk life staying there. So it is better to shift in South, because in South India, the specializations are high and nurses get good experience, and they are readily getting available to go to the international markets. So
Swati,
that is...
Swati, we are running out of time.
Yes,
Can you
that is...
please?
Yes, that is... So that is, I think, the two main things. One is getting good experience in the clinical care, and second is to get ready to go to the international markets. That's it.
Thank you, Swati.
Yes. Thank you, Swati. You raised one, for me, very confusing point, because you said we don't have a shortage of nurses in India. I wonder whether we can have brief reactions to this.
Yes, Krista, I would like to say that. Yeah. Actually, I differ with Swati. I think what she meant was, we do not have a shortage of production of nurses. We have a huge production at different levels, at the collegiate level and the GNM level. The production is huge, but the shortage in service is very, very low. And that is, I think, policy perception is the problem. Policy makers do not perceive nursing care and nurse-patient ratio as important. This is a huge struggle for Indian nursing advocates or public health advocates like me, where there is a government hospital and you need 1:5 ratio during the 3 shifts. There would be 3 doctors, but there would be 3 nurses only. Whereas there should be almost 9 nurses if you want to maintain the nurse-patient ratio equivalent to the doctor-patient ratio. This is not perceived by the policymakers. They still think a nurse can manage 20 patients at a time, and they do not see this ratio at all. And unless this hierarchy and gender inequity is perceived and addressed at policy level, this inequalities in the professional numbers in hospitals and patient care will not improve. That is a blind spot in the Indian government. And that blind spot, unless it's removed, the situation will not change, whether it is in Northeast or South or anywhere. I also disagree with Swati about getting good quality nursing experience. not allow their students to touch their patients. Therefore, I think it is basically certificate giving rather than skill training. Whatever skill they learn on their own or they learn while they are at a job. There's a dismal deterioration of nursing education, especially practical education in India, in every state now. So this is what I wanted to say.
Yeah, thank you, Prakasama. So we have to come to an end of the webinar and wind up. For me, I just want to highlight what Santosh has written into the chat, what should be done. One very important point, of course, in India is to increase the health budget, which is extremely low compared to neighboring countries, and which is a precondition to improve the situation in the health sector. So are there any very urgent statements to be made to conclude? Karin Spannenberg-Krebs from Germany has put a paper in the chat, which was published by the German Platform for Global Health. And this refers to the demands of the German government and the recruitment of nurses from abroad. So we can share this paper, but most of us, we have shared it already among the colleagues at JNU, but we can share it with the others here as well. Any concluding remarks?
Thank you very much for organizing this. It's been fascinating to listen to the other panelists.
Yes, thank you all very much. I would like to say, comparing it to the webinar last week in Ghana, for me, it's astonishing how different the two webinars were, because in Ghana, the most pressing question raised in the end was how to stop the exodus of nurses so that the healthcare sector in Ghana can be saved from collapsing, because it is close to this. And this was in the end the key question in the webinar last week. And our webinar now went into a completely different direction, much more to fair migration and how could the conditions for migration and for migrant healthcare workers abroad be improved. That's interesting, and we will go deeper in this kind of comparison between Ghana and India in our GPN project. And we will ask around among you as well whether we should have a follow-up of this webinar, because there were very, very interesting, insightful presentations here. And I thank you all for the discussion and your questions, and hope to see you at another occasion. Thank you very much. And
thank you, Krista. Thank you.
Nice
As a GPN coordinator based in JNU, on behalf of entire GPN family, let me thank you for this initiative, and to all our panelists for their excellent contribution, the entire team which was supporting you, helping you, in particular Azra, and all the participants who joined us today. I would request you to think of some concrete kind of output, which sort of would be suitable for dissemination, either a few working papers or possibly a book and so on. And hopefully all our panelists would be willing to contribute to that. So that would be sort of celebrating this particular occasion in a more tangible manner. So thank you all. Yes.
Thank you very much to
Thank you.
everybody, and bye-bye.
Thank you. Bye-bye. Thank you.
Bye.
Thank you,
Yeah,
Professor
bye-bye
Karen.
to everyone. Bye to everyone. Thank you.